Today we will cover IV bolus administration, and this is chapter 22 in your textbook. The learning objectives are to identify the equipment used for an IV bolus. We will discuss the advantages, disadvantages, and risk of administering medications IV bolus. We will also evaluate the effectiveness and the outcomes of administering medications IV bolus and demonstrate proper and safe preparation and administration of medications via bolus and lab. The image that you see on the right side of the screen is what an IV catheter looks like when it's inserted into a vessel. You can just see the catheter. It's made of a plastic-like material, and it's just kind of angled down into the vein. So that's how a patient would receive, this is the route in which the patient receives their medication. It's important that it actually stays in the vein and doesn't end up in the tissues. That would be an infiltration. IV bolus administration is skill 22-5 in your skills book. It is essentially the administration of a concentrated dose of a medication directly into the vein, and we do this through a saline lock or either through an existing IV tubing in which a patient may be receiving fluids. Remember, there are different ports on the IV tubing, and we would administer the IV push or IV bolus through the port that's closest to the patient. One advantage of administering medications via bolus is that it requires a small volume of fluid, and this is key in a patient who's at risk for fluid volume excess. We don't want to give them more fluid than they can handle. Another advantage is that medications given this route have a very quick onset of action, which is what is needed if there is an emergency type situation, a cardiac arrest, if your patient's in pain and you need pain relief quickly. Additionally, if you have a patient who's nauseous and vomiting, administering medications via IV bolus would give them a quick relief. However, we have to keep in mind that patients have to be monitored very closely because they're at greater risk for adverse reactions when a medication is given IV. Another, when we look at disadvantages of administering medications this route, because they act so quickly, you don't have a lot of time to correct any errors. Once it's pushed into the patient, it's in, and so you have to be really careful, take it seriously. Just know also if medication is given too quickly, it can actually cause death. So it's going to be important to really look up your medications, and we'll talk about what's required, but just keep in mind that it's a very dangerous method that doesn't leave time to correct any errors that might be made. IV bolus medications can cause direct irritation to the lining of the vessels because they are so concentrated. You always want to make sure that before you administer a medication through an IV, you checked to make sure that the IV is actually in the vessel and it hasn't infiltrated or moved out of the vessel into the tissues, because sometimes certain medications can be very irritating or even caustic to the surrounding tissues. So you have to be really careful about that. They can cause abscesses or sloughing off of the tissue. So we always want to make sure that the IV catheter is still in the vein before we administer anything. 4 strategies to reduce harm are to use commercially available or pharmacy prepared IV push medications whenever possible, and we always get our medications from the pharmacy, so that's usually not an issue. We want to make sure that any medications that have to be diluted as recommended by the manufacturer, the agency policy or reference literature is actually diluted, because again, it's concentrated and some medications can be really irritating to vessels. I remember when it was one of the first jobs that I had. I worked on we had a lot of surgical patients really on our unit. And back then, um, it was before Zofran, and we used to give a medication, an antiemetic called by the name of Phenergan, and it was very irritating to the veins. It would burn if you didn't dilute it and give it and push it slowly. So very important that when you look up your medications, you find out if it has to be diluted. Some have to be and some don't have to be. Additionally, when you look up medications, you will find out the rate to push it. So how fast you can push it, how many milliliters over a minute or milliliters over 5 minutes. It just depends on what the medication is. So look it up, make sure that you know what the rate is, and you go ahead and push medications according to that rate. You may see nurses do all sorts of things. You may see nurses push everything quickly, but no, onset of action is quick, and you want to push it at the recommended rate by the manufacturer or by agency policy. And another strategy to reduce harm in your patients would also be to label your syringes appropriately. So we're labeling the syringe that we're drawing up our medication in with the name of the medication, the dose and strength of the medication, the volume as well that we're going to give. Because otherwise, when we get to the bedside and we're supposed to do that third check, how can we do that third check if we don't know what we have in our syringe? So it's going to be really important to label. We're the final check to keep our patients safe. Other safety guidelines, and this is a review from our content on IV management. Make sure that you're not distracted. You're in a no interruption zone when you're drawing up your medications and you're doing your calculations. It's very important. Make sure that when you're looking at your vials of medications, when you're looking at your saline flushes, they are not expired, they're within date. You're appropriately identifying your patient. You're doing those medication checks that you're supposed to do the 3 times. If a medication order is unclear, we're clarifying that with the provider. We are following the correct policies, not using workarounds. We're using the barcode scanning technology as it should be used. Strict aseptic technique when we're preparing medications because it's going into the patient's vein. And medication administration via IV push cannot be delegated. LVNs are not allowed to administer IV push medications even if they've had the IV course. It's not something that they're able to do. Okay, continuing on with safety, we need to review the medication administration rights and checks. So remember, we do 3 checks, and we need to look at the 6 rights. So rights, right patient, right medication, dose, route, time, and documentation. We're performing checks when we are checking our order against our MAR. We're checking when we're taking medications out of the Pyxis. We are checking at the bedside as well, right before we give the medication as the final check. And just make sure that you don't forget to do that one. This is an illustration of what has a drug label first. So medication and dosage there. They're showing the patient's armband, so we're checking name, date of birth, asking about allergies, and then using barcode scanning technology as another safety check. We talked about barcode scanning, also making sure we want to make sure that your medication, anything, whether it be the syringe or the IV fluids, everything needs to be labeled appropriately. Remember that your tubing administration sets need to be labeled because they have to be changed at certain intervals. Continuous infusions every 96 hours, intermittent infusions every 24 hours. So your IV tubing, if your patient has that, it should have a label. And then so the image that's on the far right with the piggyback, you can see a label above the roller clamp. That's what you would expect to see. There's a label on the bag. You would expect to see that. And then there's a label for medications up top. And it has all of the information that you would need to provide. Actually, this is probably facility specific. Usually we just want to make sure we put the drug name, the dose that's in there, the milliliters, the volume that's there as well, and you can put your initials if you want. It's not necessary, but at least those things you need to have on your label. So it's also important to cover needle stick prevention. Needle sticks are the most frequent route of exposure to bloodborne pathogens for healthcare workers. So we need to be really careful. Most of them will occur in the patient's room or in the operating room. And they will occur when healthcare workers recap needles or mishandle needles or leave them at the patient's bedside. So we want to make sure that because you will have to use a syringe and a needle or either a blunt tip type needle to remove your medication from the vial, you need to be mindful of how to actually use the syringe. Another thing I didn't talk about was looking at the numbers to make sure you're comfortable with the calibrations on the syringes as well. But when it comes to sharps, facilities are required to stock sharps that have engineered injury protection technology, so they have to have a safety now, and you need to be familiar with how to activate the safety on all of the needles that you use. And if you're drawing up a medication at the medication cart and you need to recap, remember to use the scoop method so that you don't accidentally stick yourself. Additionally, when you oftentimes what you're going to end up doing, because when we use an IV push, the saline lock or the IV tubing, it have needleless connectors, so you're going to end up removing the needle from the actual syringe and just putting a cap back on. It's going to be a needleless thing. Make sure when you go in the patient's room, when you're scanning your environment, you're looking to see where the sharps containers are so that you'll know where to get rid of your supplies. When giving a medication IV push, there are some things that you need to know that you might not need to know if you're giving a medication by mouth, for instance. We need to always look up the medications, and when you look the medication up, of course, we're looking for potential adverse reactions that might happen, but you also want to look up if the medication needs to be diluted, and if so, with what, normal saline or sterile water. You also want to know what the rate of the push is, so how fast you can push it. You need to know if the medication is compatible with other medications or other therapies that the patient could be receiving. For instance, if your patient is receiving IV fluids, is the medication compatible with the IV fluids that you are giving? We have blood products on the screen as an example, and there isn't any medications that are compatible with blood products. If you're giving blood, then you have to start another IV site if the patient happens to need anything IV push while they're receiving the blood. You also want to check the order. You want to be aware of the concentration and the volume before you give the medication. And at the bottom of the screen, this is an example of what an IV compatibility chart might look like in a computer in micromedics. And so a lot of the computer systems will have built-in compatibility charts, which are great. They save you a lot of time until you get familiar with your IV push medications and IV fluids. So IV access. Of course, this is how we are going to administer our IV fluids through either a saline lock, or you're giving it through an existing IV that already has fluids running through them. So before we can give our IV bolus medication, we need to assess the site to make sure that the IV catheter is actually in the vein. This always has to be done before you put anything in. And the way that you do this is you start out with inspection. You're visually inspecting the site. You're looking for any redness, you're looking for any swelling, any drainage around the site. And then you will put on gloves and palpate, actually touch above, below, and the sides. You're touching, you're feeling for checking the temperature to see if there's any warmth, to see if it's excessively cool. You're touching to see if, and you're asking the patient if they have any pain while you are palpating, because that's a sign that there's a complication going on if the patient is having pain. It could be infiltrated, it could be phlebitis. So that's another thing that we would want to do. And remember, we're palpating with gloves on. And then a part of checking to make sure that the IV line is actually patent is flushing. So you will take a syringe into the room with you. Most facilities have pre-filled syringes. A lot of times they're a 10 milliliter syringe. So you are going to start with a flush, maybe about 2 to 3 milliliters of saline. So you flush the tubing first. If it flushes well, if you don't feel any resistance, that's a good sign that the IV catheter is still in the vein. Then you pull back. The first picture that you see on the left is of the nurse we call it aspirating for blood return. That gives us a good indication that the IV catheter is still in the vein. Then you need to flush that blood back through the catheter with another 2 to 3 milliliters of IV fluid. After that, after you've checked, that's checking for patency, you can go ahead and administer the medication over the recommended time in the port that's closest to the patient or through the saline lock if that's what the patient has. And then once the medication has been administered, you will end with a saline flush, 2 to 3 milliliters to flush the medication through the IV catheter. And we'll go over. Since you will be using syringes to draw up your medication, it's important to review syringes. Remember, there are different types of syringes. They're disposable, and they can be lure lock, which twist on, and they might be a non-lure lock or lure slip syringe that will actually just push on. Most of what you will use for an IV push is going to be a lure lock. If you look at the illustration, it is, let's see, at the bottom of the page where you have a syringe and then you have a needleless cap. That's usually what it looks like. And so your lure lock syringe will just twist into that needleless connector after you've cleaned it, of course. And talk about that first, but you have to actually clean off the needleless connector with alcohol for at least 15 seconds, let it dry, and then you can attach your syringe to it. You want to remember to take out all of the air from the syringe, even the little small tip should not have air in it. We don't want to introduce air into the patient's vein. Make sure that you're familiar with the calibrations that are on your syringes as well to ensure that the patient gets the correct dose. There are different sizes. We have usually 1 milliliter syringes, 3 milliliter syringes, 5, 10. There's even 20 and 30 milliliter syringes if you need to give that much. Typically, you don't need to do 20 or 30, but you may use 3 or 5. Those are ones that you might use very, very commonly. Okay, so it's also important to look at unexpected outcomes so that we know what to do if they occur. So if a patient develops an adverse reaction, if they start to develop signs and symptoms of an allergic reaction while we are administering a medication IV push, of course you want to stop that medication right away. And you want to follow the agency's protocol for treating allergic reactions, which might include the administration of some type of antihistamine or epinephrine. We'd want to notify the provider and document the allergy to the medication. Now, it may be a few minutes after you administer it that you notice the patient starts complaining of itching, or they have hives or redness, difficulty breathing. Another expected outcome might be incompatibility of medication with IV fluids. So this is a case where a patient already has a primary infusion going and you are administering a medication IV push. You would know that there's an incompatibility if you are looking at the tubing, and you should definitely look at the tubing while you are pushing it. You notice cloudiness, or you notice precipitate or crystals forming, immediately you need to stop that fluid, stop that push that you're given, stop the fluids, and remove that IV tubing. Now, some agencies might allow you to infuse IV push medications that are not compatible with fluids. If that's allowed, once you have removed the IV tubing that where the reaction has happened, and you know that it has not gone into the catheter, you may be able to flush that saline lock with 10 milliliters of normal saline or either sterile water, which would clear the line of the IV fluids. Give the medication and then follow that up with another 10 milliliters of normal saline or sterile water. And then you could restart the fluids with new tubing. That's only if your agency allows that. If the agency doesn't allow flushing for incompatible fluids and medications, you will need to start a new IV site somewhere else in order to administer the medications and restart the fluids. If your patient has signs and symptoms of infiltration or phlebitis, now when we go over IV starts, we'll talk about infiltration and phlebitis a little bit in more detail. But with infiltration, the IV catheter has actually moved out of the blood vessel and it's in the tissues. So what you will see is complaints of discomfort or pain, swelling around the site. It will feel cool. Sometimes the skin looks really tight. If there's a lot of fluid in the tissues, there could be blanching or redness. And usually what we do in this case is elevate the site. You don't necessarily have to notify the provider for an infiltration unless it's huge. Phlebitis, on the other hand, the patient will present with pain. There's usually redness. It's warm when you touch it versus being cool. There's also swelling, and you may feel a induration, so just like a hardness, especially along the length of the vessel. You may feel a hardness. And in that case, you would definitely have to notify the provider for the phlebitis. What we do when either of these conditions present, we would stop the IV infusion, discontinue that IV, and we would restart the IV in a new site. We want to assess the signs and symptoms that the patient has, and again notify the provider if the patient's has phlebitis, signs and symptoms of phlebitis. Delegation and collaboration. Again, administering medications by bolus cannot be delegated to an NAP. Remember that an LVN or LPN cannot administer medications IV push or IV bolus. We need to, what we have to do though is let the NAP know about potential signs and symptoms that need to be reported, and to let us know if the patient has any signs and symptoms of infection around the IV site, any pain, redness, swelling, if they notice any drainage or any discomfort. Also, if there is any significant change in their vital signs, they would need to report that to us as well. Recording and reporting. We would document our medication administration of the IV bolus in the MAR. We would document any notification of their healthcare provider that we might have done because of adverse reactions or issues with phlebitis at the IV site. We would also need to document the patient's response to any therapies that we initiated as a result, and and that would be in the nurse's note. Special considerations, teaching. We always teach our patients what we're giving them. We tell them the name of the medication. We tell them how it works and what the potential adverse effects might be, things that they might need to report to us. When it comes to pediatric patients, IV push medications have to be given slowly and in smaller volumes, and we need to make sure that we always follow the institutional policies on administering medications in pediatric patients. And when it comes to our elderly population, the gerontological patients, we need to be mindful that these patients oftentimes have reduced renal and metabolic systems, so the way that they metabolize medications can be impaired. They're at risk for toxicity. So we would need to especially monitor them for an increased risk of potential adverse reactions. This last slide has a practice problem for you to work on. I also have a practice problem in your DDC slides that are in Canvas as well on calculating IV bolus. And I sort of worked all of them out using dimensional analysis, as that's just an easy way to me to work out the problems. And just remember, when you're setting up a problem, you start out with what you're looking for. For example, the orders for volume, 20 milligrams IV push stat at a rate of 5 milligrams per minute. And what's available, the vial that we would remove from the Pyxis is 5 milligrams per ml. So in part A, we want to know how many milliliters we would administer to the patient. How many milliliters would we draw out of the vial? So since we are looking for milliliters, the way that we set up our problem is milliliters would be in the numerator. We'd start out with that. And if we look back at our problem, where is milliliters? Well, milliliters is associated with the 5 milligrams. That's why I put 1 milliliter over 5 milligrams. And since I want to end up with milliliters, I have to get rid of the milligrams. Look back at my problem. Where's milligrams? Well, it's in my order for 20 milligrams. So that's why 20 milligrams goes in the numerator. And when I do the math, I note that the volume of medication that I would remove from the vial would be 4 milliliters. The next thing that I need to do is figure out how many minutes it would take to administer my dose. And my drug reference says that I am to administer the medication at a rate of 5 milligrams per minute. Since my dose is 20 milligrams, I know that I would have to divide 20 milligrams by 5 milligrams, and that way I would come up with 4 minutes. So I would have to administer the 4 milliliters of volume over 4 minutes. So what would that be per minute? And you can kind of figure that out without doing any math. If I need to administer 4 milliliters over 4 minutes, it means I would administer 1 milliliter per minute in order to get the dose. And then I asked if you could figure out how many milliliters that would be every 15 seconds. Again, in C, I set the problem up. You could actually kind of figure it out without doing the math, but if you use dimensional analysis, you're going to end up with 0.25 milliliters every 15 seconds or 0.5 milliliters every 30 seconds is what we would actually
as the rate at which we would administer those 4 milliliters over 4 minutes. And again, when it comes to your calculations, I mentioned in the video on drug dosage calculations that your drug book is a really good reference. They have lots of practice problems, and the answers are in the book. I recommend that. You can come to office hours. We can work out problems on Zoom together. Just let me know. I don't want you to feel overwhelmed with math.